Hello everyone, I'm Nona, co-chair of MPN Voice, and I would like to extend a really warm welcome to everyone who's joined us today. I know we've got people in America, we've got people in Europe and people from the UK, and it's wonderful that you're able to be with us in these very, very difficult times for our second London virtual forum hosted by the team at Guy's and St Thomas's. As a patient group, we owe a huge vote of thanks to all the wonderful medical staff, not only at Guy's, but also around the world, who continue to give so much of themselves to help so many patients and families during this incredibly difficult time. I'm now happy to hand over to Professor Claire Harrison, who is going to give an overview of what to expect from this forum. I am actually not at Guy's, so may or may not have technical problems, but Claire is there to give you a lead on what is going to happen today. Thank you, Claire.
Well, thanks very much, Nona. I don't think any of us can promise not to have technical problems, but that's all part of the fun and new learning that we have. So a warm welcome to all of you from all of us at the Guy's and St Thomas's Centre. Some housekeeping. Could you try to adjust your name on your setting so that we can see your first and last name, so that we can help to answer a question, but also to move you into the right breakout group. So we've been doing forums throughout this year, but this is the first one we've done where we've tried to move people into breakout groups. And we've got over 140 people planned to join us today, and we're already up to 95. So we really need your help. Instructions will be posted in the chat for if you're not sure how to do that. We've got lots of questions that have come in, but this, as ever, is an interactive session. So please do feel free to put your questions in the chat box. We do have a panel session, but we also have some breakout groups. We will not, however, be able to answer any questions about individual treatment. That's not really appropriate. If you can, please try to remain on mute during the talks and when you're not speaking, because we've got lots of people and it's got the potential for being a bit noisy. Lastly, I just want to say, in terms of formal instruction, please can you fill out the feedback survey, because that will help us as a team at Guy's, but also as an MPN Voice team, to know what was good, what was less good, what you want to have more of in the future, etc. And this is all really rather experimental at this point for us. This is the agenda. So we're already part of the way through that. I'm going to hand back to Nona in a minute, who's going to talk a bit about MPN Voice. Then we've got 4 talks, one from myself and one from Dr McLornan. And then we're really grateful to Caroline and to Sarah, who are going to also speak and share some experiences. We'll then move to a panel Q&A session, which will involve the team at Guy's and St Thomas's. Nona will also be on the panel, and we will try to answer questions at that time. After the panel, we will have a comfort break, because we'll all need to stand up and move around a bit at that point, I think. During that time, go and get a cup of coffee or whatever. And in that time, we will drop you into the appropriate breakout group. If that should happen automatically, and you can help us by making sure your name is correct. If you have a prompt that says accept related to this meeting and Zoom, please just accept it. If you end up in the wrong breakout group, please just grin and bear it, and we'll try our best. At the end of the breakout groups, you will automatically be dropped back into a feedback session, which Nona will be running. So I want to just start by thanking all of the Guy's team for supporting the forum, including Danny Palmer, who you've all heard from and is in the room today, Tam, who's in the back office, also helping, and Drew and Dean, who are helping to make sure that all of the AV works. And I also have called out all of the names of the team at Guy's who are going to be with us today, joining us and helping. And I'm really, really grateful to them for everything they do for our patients as a team and for supporting us in pulling this together today. Because this is one of the things that the coronavirus pandemic has taken away from us. It's taken away the ability to meet with people and to share and interchange. And this is what we're really trying to do today, and to bring back the spirit of some of the forums that we've had before. So bear with us, we'll learn together, and let's see how we go. So Nona, over to you.
Thank you, Claire. And many of you may have seen this presentation before, but I know there are some new people who've joined us for the first time. So Maz and I have worked to change it slightly so that you don't see the same presentation. But MPN Voice, who we are, formed in 2003 by a small group of patients led by Claire and her team then at St. Thomas's, with specialist nurses, psychologists and doctors, became MPD Voice in 2011, and then because of the World Health Organization's reclassification, MPN Voice in 2013. You'll see the little sign that says Guy's and St. Thomas's Charity, and that is because we're under the auspices of Guy's and St. Thomas's Charity, and who help us with all the Charity Commission bits and bobs we have to do. What do? We provide a mass of information. When I was first diagnosed in September 1991, which is 30 years ago this September, there was precious little information about. And one of the things that drew me to be committed to MPN Voice was to ensure that nobody would have to go through that, and that there would be always accurate information up to date. We provide all aspects through our website. It's just been revamped, so I suggest that if you can, you look at the website. The YouTube channel, this forum will be up on the YouTube channel tomorrow, we hope, or certainly by the end of the week. The buddy support system, the leaflets, the Facebook page, Twitter and Health Unlocked. We keep an eye on all of those things so that we can ensure that you are given up-to-date information. Coronavirus has created so much for so many people to make sure that we give our community the most up-to-date information possible. At the start of the pandemic last year, we really had to revamp MPN Voice to be able to deliver all this. So we now have an executive committee, which is led by Claire and John, Matthias, Tim and myself, a management committee with our wonderful Maz, who many of you know is our most brilliant administrator, and then a committee of doctors. Everybody works together to make sure that we give you the best information we can. And that includes monitoring Health Unlocked and Facebook, and actually updating everything as the situation changes. You know, I have to say, this is now nearly a year old, this situation, and I have to thank everybody who has helped us keep it so up to date. We have delivered 2 virtual patient forums, one for Ireland and one here, and we also collaborated with Leukemia Care to deliver a webinar. As Claire said, this is the way we have to be at the moment, but we cannot wait to get back to a new normal of being to interact with our patients. The surveys that we have conducted have been used internationally to help organizations with clinical care approaches to COVID. The forums, the regional forums, which sadly now can't take place, And we just look at the length and breadth from where we started at St Thomas's to where we reach out to now. And we're hoping that we will be doing some more virtual forums from the regions as soon as we can organise them. And this is a map of the world. And it just shows that last year our virtual forums were attended by people across the globe. And I once said to Claire, MPN Voice is no longer a little acorn, it's an oak. Claire said to me, it's a forest now. And it gives me huge pride for everybody who's been involved in this, just to see how far we reach out to the patient community. Research, that is key. And I'm not going to talk too much about research because I know that Claire will be talking about it. And it is clearly one of the things that we hear time and time again. Will there be a cure? Why did I get it? Are there any better drug treatments or new treatments on the way? Mithridate, again, Claire, I'm sure will mention this. We are helping fund this particular study. Thank you. I almost feel like the Downing Street people who say, next slide, please, because sitting at home doing this, forgive me if there's a little gap. The Mosaic study, I know, means an awful lot to a lot of patients, and a lot of money has been raised for patients for this particular study. We will be giving you an update soon. We're in the process of getting together with Leslie Anderson to provide that information. Advocacy. This is relatively new. I say relatively new, but it's a really, really important part of what we do. And I'm not again going to talk too much about it because Caroline, our patient speaker, is very much involved with advocacy, but it really has given the patient community a voice in terms of with the drug companies and in terms of what the patient community want and need. Fundraising, we have to raise funds. To do this, we raise funds for the projects that I've just mentioned, to run the patients' forums, for the development of the website, for printed resources, providing support for the MPN community via HealthLock, Facebook and Twitter, and general support to the MPN patient and healthcare communities. And if you'd like to know how to get involved, please contact fundraising at MPN Voice. There is one little thing I would like to point out, is that these little cards, I don't know if you can see them, these are one of the things that have been donated by a patient. And they are a card that you can carry in your wallet that actually says what MPN you have, what drug regime you're on. So if in the unfortunate time you're in an accident, you have the information ready at hand to give to a doctor. And thank you to that donor. The fundraising, fun is what it's about. Fundraising is as little as tea for two or as big as running a marathon. But I think what I've learned from being involved with MPN Voice is it provides a sense of community. Nobody is alone. Everybody can join in with something small or something large, and we know that it all goes to a good cause. I think that the team that are running the fundraising now, led by Marilyn and Maz, are in the regions. And if you contact info@mpnvoice.org.uk, Maz will give you your local person that you can make contact with. Donations. We do need money to raise, to provide the studies that I've already spoken about. Raising funds during the COVID crisis has been problematic for everyone. If you do feel like giving to MPN Voice, please feel free to get in touch with the website connection. And if you've got any queries, please go to info@mpnvoice.org.uk and Maz will answer them for you. I cannot thank you enough, and on behalf of the executive team, the management team, and the medical team, thank you for joining in and thank you for your ongoing support. I would now like to, introduce Claire, who is going to talk to us about the updates from the ASH meeting and the origins of MPN. Thank you, Claire, and thank you for all you do for all of us.
Thank you, Nona. Just while we've been sitting here, of course, I'm attached to my phone. I just wanted to acknowledge some really sad news that's just come in from I've just seen it on the news feed, that very, very sadly, Captain Tom has passed away, which is obviously very, very sad. I think at some point in this forum, we will all be thinking about and remembering everybody who's had an impact during this terrible, terrible year. But I think it would be bad at this point to just go on without acknowledging somebody who was a true hero and really has made a huge impact. So I just wanted to take a moment to acknowledge him. He's been truly inspiring for the NHS and for all of us. So I hope he rests in peace. But I'm sure he'd want us all to go on and to move on and to push the boundaries and to do our best to improve things. And that's what obviously we're going to talk about today. And so we've got 2 medical talks. We try not to make it too jargony for you. We just had a big interactive meeting. We usually like traveling across the globe, across the Atlantic Ocean to North America just before Christmas. We usually get snowed in, have some horrendous travel stories and come back with lots of updates about these conditions. And the meeting we go to is called the American Society of Hematology. It's a massive meeting with tens of thousands of delegates, and we even managed to deliver that online. That inspired me to think we could definitely do an interactive forum. So I'm going to give you some updates, and then my colleague Donal McLornan, who many of you will know, will also give you some updates. One of the first updates I want to talk about is this presentation given by Jyoti Nangalia from Cambridge, talking about the question, how long have I had this condition? And using some very, very complicated genomics to track back a mutation. So I'll try to explain it to you. Unfortunately, Jyoti is homeschooling her 3 children, so couldn't manage to give a talk today, but she gives an amazing talk. I only hope I can just do it a bit of justice. But so, MPNs, as we know, are chronic blood conditions. And many of you who are watching will have one of these 3 common conditions: polycythemia vera, ET, or myelofibrosis. They are conditions which we can study quite easily because, unluckily for you, but lucky for us, we can stick a needle into your vein and sample your cancer pretty much multiple times. And I know we like doing that. That means that we can easily take samples and check on the progress of the condition in terms of genomics. That means that we can try to answer, and this is what Jyoti has tried to do, how long have I had this condition for and how fast did it grow? Many patients with MPNs have got a mutation in one of what we call the driver genes, JAK2, calreticulin, or MPL. But about 2/3 of patients also have mutations in additional genes. And that's what's reflected across the bottom part of the slide. This is some of Jyoti's earlier work, golly, almost 7 years ago, where we took about 2,000 patients from across the UK and sequenced them in the Sanger Centre. So what she's done in this work is actually so beautifully, elegantly simple, but so complicated at the same time. So she's taken 10 patients, and you can see them across the top left of the slide. And each of those patients, all diagnosed at different time points from age 20 up to age 78. And she's taken samples from them and grown them on a plate. Now, these patients have got all of the different diagnoses. So blue is ET, pink is polycythemia vera, and yellow is myelofibrosis. Some of them are men and some of them are women. And what she did when she grew their blood on this little plate was she was able to look at one single seed cell or stem cell in each of the little blobs that grew from them, for want of a more technical word, on the plate. And what she was then able to do was sequence the whole genome for each of these so-called colonies. So there's almost 1,000 colonies for each patient. And just to put it in context, the massive expansion of science, 5 years ago or 7 years ago when she was doing the other work, she was sequencing colonies only for JAK2, CALR and MPL. But now we can sequence the whole genome for these colonies. And so what we can do then is look at individual stem cells and use the mutations as barcodes and track them back up to the earliest time in life. What on earth does that mean and how was it done? So this is what's called a phylogenetic tree. And so what you can see, if you look at the expanded picture on the right of the slide, it's like a family tree. So it would be like, if you like, the ancestor would be at the top of the straight line, then the parents, then one of those parents has two offsprings, which are unique because they arise because they've got different mutations. So then you can draw up a family tree, not according to when things are born in the way that we think, but when a new type of cell is born because there is a new mutation. So what you can then do, what she was then able to do, was put the mutations according to how they appear in the colony. So if you look at this particular example, green appears in all of the colonies below it, whereas blue would appear only in the colonies below that. So you can then start to kind of carbon date what has happened. And one of the first things she was able to do was to look at the number of mutations that occurred in these patients roughly per year, and able to work out that around 80 new mutations were occurring per year. And then she was able to look at different examples. I'm not going to show you all of this work, and we'll try to point you to somewhere on YouTube, for example, where you can see it. But just here's one example of a patient who was diagnosed with ET age 21. The sample was taken when the patient was 23. But if you look at the right-hand side of the slide, you can see that the JAK2 mutation arose in this individual by using this very complex computational genetics sometime between when they were 6.2 weeks old, don't ask me how they worked out 0.2 weeks, to 1.3 years old. So sometime in the first year of life, this patient developed a JAK2 mutation in their stem cells and became diagnosed with ET 20 years later. Some patients are much more complicated, and I'm not going to go through this slide in detail because it's just the essence of the work that I want to emphasize to you today. And many patients do have mutations that don't really relate to their disease. This is something we're starting to understand as we have these very powerful tools. But some mutations, for example, the one ringed on the right-hand side, known as DNMT3A, in this particular patient, arose before the patient was born. So there is evidence then that for patients with MPN, these 10 patients that Jyoti took, and there was nothing special about those patients, they were just patients at Adam Brooks that they selected, that these mutations were happening at a very, very early stage in life. Some patients' clones grew very quickly, others grew more slowly, and that's what the fourth bullet point on this summary slide, which is a bit blurry, apologies for that, means. So basically, those whose clone expands more rapidly generally were diagnosed more early on. And this is so important and so exciting. It gives us a lovely window on what might well be happening. And it might enable us in the future to be able to think about prevention strategies, but also importantly, many patients with MPN are diagnosed with a big blood clot. So if you had one of these mutations detected in your blood, for example, then you could be put on a drug like aspirin, which might help prevent the blood clot earlier. So that's the kind of summary. This will, of course, complement the MOSAIC study, which is being undertaken by Mary Frances McMullen and Andrew Dunscan and Leslie Anderson, and sponsored by MPN Voice. So it doesn't replace it, but it will basically add more pictures to, well, why did these mutations happen? So next I want to focus on therapeutics. And the first thing I want to talk about is the calreticulin mutation. So around a third of patients with ET or PV will have a calreticulin mutation. And there are many different mutations, about 40 of them. What we have come to understand is that that mutation, WT means wild type, MUT means mutation, causes part of the calreticulin to be chopped off. And that chopped off or truncated calreticulin comes out of the cell into the blood. We can measure it in the blood, but it also binds to a receptor known as MPL, which is the receptor for the platelet hormone, and triggers the production of platelets. And that is probably why the calreticulin mutation is linked to disorders with a high platelet count. Okay, we knew that. Why is that important? Well, it's important because if the calreticulin mutated form is on the outside of the cell, our body may well be able to recognize that. And we know that some patients who've got mutated CALR actually do have antibodies. And more recently, a group in Japan has been able to make an antibody, the purple one, B3, that recognizes the mutated calreticulin on the outside of the cells. So this is something that was presented at the ASH meeting. And the exciting thing that was presented in the ASH meeting was when they used a mouse model of ET driven by calreticulin, they were able to show that giving this antibody, B3 chimera, compared to just giving a placebo, otherwise known as vehicle, the mice dropped their platelet count, which is what you can see on the left. In the middle, you can see their bone marrow, which had fewer megakaryocytes, and we need to fix a pointer for these meetings, but the megakaryocytes are the bigger cells in the middle, and they're fewer on the right, and their number also dropped. So this is really exciting. It's the first time we've seen this kind of technology. It won't be coming into humans next year, but it will hopefully be coming soon. So we could perhaps discuss that. And it's the first demonstration that an antibody to calreticulin might be of benefit. Next, a brief update on interferon. And in France, our colleagues at the Hôpital Saint-Louis, which actually we are, as an MPN service, twinned with, have been doing a study looking at stopping interferon. Our practice is usually to reduce the dose. And there are some people I know in this meeting who are on a very low dose of interferon. But Jean-Jacques Kelagin and the team in Paris often will stop the interferon. So what they did was they took their cohort of patients. They've got about 1,250 MPN patients, 469 of them treated with MPN, and about 300 of them stopped. They chose patients who had received at least 3 months of interferon and stopped for at least 3 months. And the reasons they stopped are shown on the left-hand side of the slide. Around a third because they had a good response. Around a third because they had a toxicity, that means a side effect. Some because they had a disease progression, and there's always a box called other. But the important message from here was that there were patients who could stop, and the patients who could stop generally had a lower amount of JAK2 detectable and had had at least 24 months of stable blood count control. Furthermore, once they did stop, if they had to restart, the patients got the response back. So in France, they will be doing a trial looking at stopping interferon. So maybe we'll be discussing that in some of our breakout groups a bit later. And lastly, actually, I can already see somebody submitted a question on this. So well done for being hot off the press. This is about a new therapy for polycythemia vera. New agents often have letters and numbers. This is PTG 300. And this is some data that was presented at the ASH meeting about this new molecule. So first, some background about what the molecule does. And before we talk about that, I need to talk to you about iron and how iron moves through the body. So we absorb iron through our gut, and it gets released into the blood through something called ferroportin, or FPN. And that ferroportin is open when a molecule called hepcidin is present in at low concentration. So for patients who've got iron deficiency, they have usually low hepcidin levels. If you have high hepcidin, on the other hand, hepcidin blocks ferroportin and you don't uptake iron into your blood. So what PTG 300 is it's a pepsidin mimicking molecule. So it will block iron uptake. So no matter how much iron the patient eats, it doesn't go through into their blood, and it won't go into their bone marrow, which is obviously important when it comes to thinking about production of red cells. So what they presented at the meeting was 18 patients who received various doses of PTG 300, hepcidin-like molecule blocking iron uptake. So effectively causing a venesection-like effect on the body. So patients have been dosed for between 5 and 54 weeks. And if you look at this, this is called a swimmer plot. And if you think about the 18 patients, each of them swimming along in its lane, which is a horizontal line. On the left, in grey, is what the patients had before they received PTG 300, and every red blob is a venesection or phlebotomy. And on the right, they're swimming along in the purple lanes now because they're having PTG 300. And you can see how few venesections were required for the patients after they received the drug. So the hematocrit, packed cell volume, which is something we monitor for patients with PV, came down nicely. The red cell count also came down. All the stars mean statistically significant. But the white cell count and the platelet count were not affected. And as a consequence, iron stores could be normalized for patients. So we weren't actually removing iron, it was still there. The patients just were not taking more up, which was then fueling the bone marrow to produce red cells. Interestingly, the symptom score for patients dropped over the course of the study. So this is an addition of every single symptom scored out of 10 that the patients had. And particular things that we think are linked to iron deficiency, so problems with feeling tired or the broader concept of fatigue, itching or pruritus and concentration, were all improved for patients with this therapy. Now, there are all sorts of issues with this. Of course, you have to give it every week. It's an open label. Patients knew they were having it, so maybe there was a placebo effect. And numbers are small, but it's still very interesting and exciting. So I think this might be an effective new therapy for PV patients. And watch this space. We're trying to get some of this agent to try in the UK. So I'm going to hand over now to Caroline, who I'm really grateful to. Caroline, are you there?
Yes, I am.
Perfect. So Caroline, thank you so much for joining us today. And I'm really looking forward to hearing you speak.
Thank you. It's nice to see you, Claire.
And you.
Okay, hello everyone. Thank you for inviting me to talk today. So I'm going to be talking about having essential thrombocythemia and going through pregnancy. I'll also be talking a bit about my advocacy role with MPN Voice. So a little bit of background. I was diagnosed in 2014. I was 34 years old. I wanted to start a family. Now, I understood that there was an increased risk to both the baby in pregnancy and me after, which was a cause for concern. I knew that I would need close care and increased monitoring through any pregnancies. But otherwise, I was a fit, healthy, young person. I had low risk ET. I was on watch and wait, no medication. So spoiler alert, I've now had 2 pregnancies, both resulted in 2 healthy babies. One of them's now 4 and the other one's 2, so not babies anymore. So in both pregnancies, I had 3 branches of care. So I switched hematologist from Claire to Susan Robinson, who's a specialist, a hematologist who specializes in pregnancy, working at Guy's. I also had an obstetrician and then a specialist midwife team, who were the ones that I saw most frequently. I'll share an encouraging moment. Early in my first pregnancy, I had my first appointment with my obstetrician, and she looked at my notes and she looked at me and she said, "I'm not sure why you've been referred to me, why you're under my care. I deal with very high-risk pregnancies and I don't think that this is a high-risk pregnancy." So that was incredibly encouraging. It put things in perspective. Both pregnancies, however, were quite medicalized, which I think you would expect if you have 3 teams of clinicians looking after you. There were lots of appointments, there was lots of monitoring, there were lots of scans, the usual scans that any healthy person has in pregnancy, plus growth scans from 28 weeks. There are pros and cons to that. One of the pros is you get to see your baby more frequently. About me in pregnancy, I did get very tired. Who knows if that was the ET or just being pregnant in my late 30s. I suspect it was a bit of both. I did become anemic, iron deficiency anemia. So I had to have iron infusions, several of them through both pregnancies, I seem to remember. They did help. I did notice a week or 2 after each infusion, my energy levels soared. So that was worthwhile. My platelets dropped in both pregnancies. I was told that that was to be expected. My platelets used to, before getting pregnant for the first time, they used to hover around 1,200 to 1,500. When I got pregnant for the first time, they dropped down to around 600, 700, which was lovely. I was told that they would return to usual, so i.e. up to 1,200 after delivery, but they never did. They remained low, and in my second pregnancy they dropped again and they remained low, and they still haven't gone back to the numbers that I used to see before getting pregnant. I sometimes joke with my partner that perhaps our children have cured me, because my platelets sometimes feel more like a healthy person's platelets. So I said that there was a medicalized approach to my pregnancy, and there was. I felt that there was. But however, despite that, I was able to deliver how I wanted. The ET didn't have too much of an impact on the way that I wanted to deliver. So the first pregnancy, I wanted to deliver in the home from home ward at the hospital. I had to meet various people, talk to all my clinical teams, the obstetrician, the hematologist, and the director for the home from home ward, because normally they only admit low risk pregnancies, which, because of the ET, it didn't class as a low risk pregnancy, but it wasn't a very high risk pregnancy. So I had to meet various people, but as long as I understood the risks, which were low, then it was fine for me to deliver in the home from home. So I was healthy enough to be accepted for that. The second pregnancy, I wanted to deliver at home. Again, it was my decision, as long as I understood the risks, which were made very clear to me, and the risks were pretty low. Then I could deliver in whichever way that I wanted. Now, due to my preferred delivery settings, I wanted to avoid induction. And for patients with ET, there is a slightly higher risk, I understand, of late-term baby loss if you go over term. So induction, I believe, is usually recommended around 40 weeks. At least it was with me. Again, it was important to me to deliver in the way that I wanted to. So I discussed the risks with all of my different healthcare teams, and I pushed back on it. I felt that the risks were small, and I was confident. I felt quite instinctive that everything was going to go well. We agreed to extra monitoring if I went over 40 weeks, which I did. I went to 41 weeks with both pregnancies. And I had to go into hospital, I think, every day or every 2 days to have various monitoring done. I think I had an extra growth scan in that time, just to check that baby was okay and that there weren't any obstructions through the placenta to baby, which would have been a result of a clot. But that meant that I could wait for spontaneous labour. Post-delivery, that's where the risk falls on the mother more, I believe. So I had to have a jab every day of low molecular weight heparin. It's one of those stabby jabs, not very pleasant. My partner had to do it for me. That was for 6 weeks. My overall experience of being pregnant with essential thrombocythemia was that the ET didn't really impact that much on the pregnancy. It wasn't a big deal. It meant that the pregnancy was more medicalized. There were more people taking care of me. So a healthy woman would only go and see the midwife every now and again. It's not kind of every 2 weeks you're having some kind of monitoring done, which it was in my case. But I was able to push back against the medicalization if I felt like the risks were worth taking, which a lot of the time I did, because the risks weren't very high. I was more tired, but who knows whether that was just pregnancy or whether it was the ET. I suspect it was a bit of both, especially with the iron deficiency anemia. But in general, when I was diagnosed, I was quite concerned about the idea of pregnancy and ET. There was nothing to worry about. Everything turned out well. So that is pregnancy with essential thrombocythemia in 7 minutes, which, if only that, it took 7 minutes to have a baby. Right. So the next thing that I'm going to talk about is my advocacy role with MPN Voice. So when I was diagnosed, I wanted to create a positive experience from the diagnosis. I was intrigued by advocacy. I didn't really know what it was, but I found out more about it. I spoke to John, who gave me a lot of information about what they were trying to do, and it all seemed like a good fit with my skills. It felt like I had something to learn and something to contribute. So what is advocacy? In a nutshell, it's speaking on behalf of patients. The aim is to ease the flow of information between us and clinicians, pharmaceutical companies, and the drug approver, which in this country is NICE. In my role as a patient advocate, I have appeared as a patient expert at a NICE technology appraisal for ruxolitinib for MF patients that was approved. The committee meeting was an interesting experience, talking on behalf of patients. I did a lot of research before appearing at the committee meeting. I spoke to lots of MF patients to learn about the experience of having MF, and then the experience of taking MF and how that changes things, how that improves things. It's all about finding out what's important to patients, and then how does the drug deliver on those things. I'm currently preparing for second appearance at a NICE appraisal. They're due to appraise fedratinib for MF patients. If anyone out there listening has experience of taking fedratinib, please get in contact. And also, if anyone out there listening is interested in becoming an advocate, again, please get in contact. I believe that advocacy is a very important part of MPN Voice's activities. It's very important to have a systematic, informed, consistent approach to sharing our story, not just with NICE, but it's very important that NICE understand the patient experience and the key issues that affect us. It's important that we can provide access to the patient community and patient data for these technology appraisals. Basically, the more convincing an argument that we can present about what it's like to live with these conditions and then what the drug does for us, the more that supports their decision making. And I think that's all in our favor, because I think the burden of MPNs is often misunderstood and underestimated. It's also a very small, relatively small patient population, and the emerging therapies are pretty expensive. So the more we're able to present a convincing argument, the better it is for us. So that's my work for MPN Advocacy. I think I'll be around for the panel session, the panel questions and answers later. So if anyone has any questions about pregnancy or advocacy, I will be around later to answer them. Thank you.
That's amazing, Caroline. Thank you very, very much.
You're welcome.
I remember your pregnancies. It would be... And looking forward to seeing your children again. Oh, fantastic.
They're lovely. They are lovely. Thank you.
And I would say we need to also say a huge thank you to Caroline, because she's put a huge effort into the ruxolitinib appraisal. It's very daunting sitting around a table with all of the health economics experts who know a lot about statistics, but Caroline just perfectly, absolutely perfectly puts across the patient voice. So now I'm going to hand over to my colleague, Donal McLornan. We can see your slides, Donal. So really pleased. Thank you very much for giving your talk on myelofibrosis and jumping then across to MPN and the immune response to COVID-19. Thanks.
Oh, thanks so much. So thanks everyone for the opportunity just to talk about two pivotal studies for myelofibrosis, and then some hot off the press data that we've been looking at, focusing on the immune response to COVID in patients with MPN. So the two studies I'm going to talk about, one focuses on patients with myelofibrosis who've been previously exposed to ruxolitinib but have lost response, and also a study looking at patients who've not experienced a JAK inhibitor before. So Novita Clax is a drug that many of us on the call may have heard of. This class of drugs is really revolutionizing not only MPN, but also MDS and acute myeloid leukemia. And Novita Clax is a tablet. And really it's called an inhibitor of anti-apoptotic. So that's a fancy word for molecules within the bone marrow that stop proliferating cells from continuing to divide. So really what we wanted to see was, does the combination of Novita Clax and ruxolitinib improve responses? So lab analysis and animal models of myelofibrosis previously, prior to the trial, showed that combining JAK inhibitors such as ruxolitinib and Novita Clax, which is a BCL2, BCL-XL inhibitor, led to better responses. And there's currently a phase 2 trial that was open at many centers across Europe that looked at this combination. So this was for patients with primary or secondary myelofibrosis who had previously had ruxolitinib for at least 12 weeks. And they were then continued ruxolitinib therapy, and there was a ramp up in dosaging of Novita Clax to try to find the best dose of Novita Clax that worked with ruxolitinib. And like most of the myelofibrosis trials we're familiar with, we looked at spleen responses, symptom responses, and then where I'm focusing today is really on changes in bone marrow fibrosis, and also did other mutations out with JAK2 affect the results that were obtained. So this was an analysis of the first 34 patients who were enrolled. The patients who were enrolled had a median age of 68. We had around 20 months median average exposure to ruxolitinib prior to enrollment in the trial. And 27 of the patients, or almost 80%, were JAK2 mutated, and the remainder had evidence of calreticulin mutation. So you'll see this term HMR. So that stands for high molecular risk mutations. And these are when you hear your doctor or nurse specialist talk about performing a myeloid gene panel. This is when we assess for the presence of these other mutations that can be in the background to mutations such as JAK2, CALR, or MPL. And they can affect the overall outcome long-term with the journey with myelofibrosis. So what they really wanted to look at in this study was, does the presence of these mutations affect the response to the combination? So we can see that, very interestingly, within 6 months of treatment, around 1/5 of patients had improvements in bone marrow fibrosis. So not only were we seeing spleen responses and symptom responses, but we're also seeing changes in the amount of fibrosis within the bone marrow. So there's a potential of disease modification. And also, most importantly, when they analyzed the background mutation landscape, the presence of these high-risk mutations and also the number of these high-risk mutations did not affect the overall response to the drug. So that's very encouraging data, that even in the presence of these mutations, at least one or more, the patients treated with the combination had similar results overall. And here you can see this is a fancy way of showing changes in the amount of the mutations in the background that were present, and for those patients who had changes in bone marrow fibrosis. So in conclusion, the EHA in 2020 presented the initial results as regards spleen and symptom responses. And at ASH last year, we saw updated results that the presence of these high-risk mutations did not affect the overall response. We're seeing changes in bone marrow fibrosis. And also they did a cytokine analysis looking at inflammatory molecules in the blood, and showing that actually decreases in certain signatures of these molecules associated with both spleen and symptom responses. The second study I just very briefly want to talk about is the MANIFEST study. So this is another class of drugs many of us have heard of before, called Abet inhibitors. Why are they important? So when we inhibit these BET proteins, we reduce inflammation within the bone marrow, and we suppress cells that are driving the fibrosis and also driving the proliferation. So it's a bit like putting your foot on the brake of the inflammation that's happening within the bone marrow. So I'm focusing here on patients who had not been treated with JAK inhibitor before. And when we look at these patients, they were given a combination of the BET inhibitor CPI and ruxolitinib, and we looked at spleen and symptom responses. The mean age of patients was 67, and very admirably, 2/3 of patients had a spleen volume reduction of at least 35% from baseline when they were assessed at the 6-month mark. Very importantly, we know that anemia is often a challenge for patients with myelofibrosis. And when you look at this orange line, you can see that patients who were anemic at the time of enrollment had improvements in their hemoglobin as they went through the cycles of combination therapy. And importantly, just like the other study I've shown, there was improvements in a sub-selection of patients in not only the amount of bone marrow fibrosis that was observed, and here you can see what we look at when we see down the microscope, very hypercellular bone marrow that shows very typical features of myelofibrosis with grade 3 fibrosis. And on the right-hand side, we can see that actually after 6 months of treatment, we're seeing more normalization of the bone marrow landscape and a reduction in fibrosis as well. So these are very early encouraging results with the combination of CPI 0610 and ruxolitinib. The drug combination overall was well tolerated, mainly gastrointestinal upset and taste changes. And there will be trials opening at a number of centres called the Manifest-2 phase 3 study, which is going to be a large international study looking at this combination versus placebo and ruxolitinib to evaluate these responses in a larger cohort of patients. I'm now changing tack very completely to look at the immune system and a topic at the minute which is very important to all of us. So the immune system, in brief, is a really complex network of not only cells, tissues, organs that function together to defend the body against foreign invaders, including viruses. It's amazingly complex, and it can recognize millions and remember millions of different enemies to mount an effective defense mechanism. This is a very busy slide, but this really shows you what the initial, what we call the adaptive humoral immune response is to COVID-19. So COVID-19 is an RNA virus. In very simplistic terms, it has an S protein, a membrane protein, and a nucleocapsid protein. It enters into the cells via a receptor called ACE2, and inside the cells, it hijacks the nucleus and the machinery of the cells to replicate and then destroys the cell. Now, what we really want to happen is that the immune system recognizes this happening and stops proliferation of the virus. We have antigen presenting cells that break down the virus and then present it to various members of the adaptive immune system. First of all, these are T cells, and T helper cells mount a response and ultimately recruit B cells to make antibodies against the virus. And if you see the number 6 in the middle of the slide, that is effective antibodies. You may have heard this term in the news called neutralizing antibodies that attach to the virus and cause destruction. The T cells not only respond by recruiting B cells, but you can also have a T cell family subset called the cytotoxic T cell, which is shown in red on the right-hand side of the slide, that really produce a lot of inflammation to destroy virus-containing cells and stop proliferation and stop COVID-19 in its tracks. Now, we're only learning for all of us how the immune system responds fully to COVID-19. We can see early and very fast immune responses, most likely in people who have COVID-19 and are completely asymptomatic. For those who have mild to moderate disease, we get a marked amount of inflammation when the system first meets the virus. We get an interferon response, which is very pro-inflammatory. And then ultimately, if our immune system can do so, we get antibodies and T cells that lead to resolution of the virus, clearance of the virus. And unfortunately for patients or individuals who have severe disease, we get a marked out of controlled inflammatory response. The immune system becomes exhausted, and we get a constant cycle of inflammation and multi-organ problems. So what we really wanted to do was to look at some of our patients and colleagues who'd been exposed to COVID-19, so a natural infection. This has nothing to do with vaccination, and to look at the T cell responses in those individuals. We had 6 healthcare workers who had had characteristic symptoms of COVID-19, including fever, cough, loss of taste, loss of sense of smell, muscle aches and pains, or gastrointestinal symptoms. I don't know why that healthcare worker just flew off the screen, but it did. So we also had patients who very kindly, let's see. Yeah, here we go. We also had patients who very kindly donated blood samples who had a history of COVID-19 infection. Now, for those patients,
they're all going off to get vaccinations, do you think?
I do not know what is happening the slide, but anyway. So for those patients, just to summarize, we had a total of 7 patients. We had 3 patients with chronic myeloid leukemia. we had 1 patient with myelofibrosis, 2 with essential thrombocythemia, and 1 patient with PV. Of note, none of these patients were on cytoreductive therapy. They all had the characteristic symptoms and a positive test for COVID-19, and the time between exposure to the virus and sampling ranged from anywhere between 6 weeks up to 38 weeks. Let's see if they're still moving. Okay. So what we wanted to do was, if you remember back to the slide looking at the proteins in the lab, we collected the blood samples, we isolated the T cells, and then tried to investigate, did the T cells have a memory to the proteins of the COVID-19? So was there a memory formation against COVID-19? I'll get there eventually.
They're all coming into clinic now.
Yeah, so importantly, and this is one of the most important slides, we also had individuals who did not have exposure to COVID-19. And on where you see the blue arrow on the right-hand side of the slide, you can see that we have patients and individuals who had no memory of COVID-19, so they did not mount a T-cell response. We can see that for healthcare workers who did not have an MPN or CML, we saw a memory T-cell response against all proteins, so M, S, and N proteins. And very importantly, for the 4 MPN and 3 CML patients, there was no difference in the memory T-cell response compared to the healthcare workers who did not have an MPN. I'm going to end this show to be able to go to the next slide without all that animation. So really, how did we do that in the lab? So this is the slide of one of our patients with ET who attends our clinic, a 65-year-old gentleman. And here you can see what we actually see in the lab when we look at the flow cytometry plots. So this circle in the middle of the top left is unstimulated T cells before we've exposed them to the proteins of the COVID-19 vaccine. Importantly, you can see for M, which is in the top right, N protein, bottom left, and in the bottom right, the very pathogenic S protein, he is mounting a very robust response when in vitro in the lab, he has re-exposed his T cells to the COVID-19 proteins. So what does that mean? We know that from all the studies to date, the T cell response following exposure is very dynamic and dependent not only on the individual's characteristics, but also the severity of the infection. Amongst our MPN and CML patients, we saw a CD4 T cell response against each of those proteins, and that did not differ from our healthcare workers in this small study. And of note, the age of MPN and CML patients was older by at least a decade compared to healthcare workers. And hence we have demonstrated for the first time that patients with MPN can mount functional memory T cell responses following natural infection with COVID-19. And for the CML cohort who were on tyrosine kinase inhibitors, such as imatinib, nilotinib, and ponatinib, there was no attenuation of this T cell response. Importantly, however, the caveat is that none of these individuals were on active treatment with hydroxycarbamide interferon or ruxolitinib. And we know that these drugs can have potential immunomodulatory effects, and we are studying the immune response to COVID-19 from individuals who are on these agents. And we also need to understand the role of age. And I'm going to finish my talk just to say that within GUYS, the team that have looked at this, and it's led by Patrick Harrington, who's one of our senior clinical fellows within the team at GUYS. He has done all of this work that I've presented on behalf of our team today, which is really excellent work. And he has set up a study to investigate the immune response to the vaccine in patients with MPN who may or may not be on treatment. And this is really important work that will help us understand the response, how long such a response lasts, and if the therapies we use within the field of MPN will have an effect or not on the vaccine responses. So you may actually, if you attend our centre, be approached for some blood samples before and after your vaccine dosing to assess if there is an immune memory response. And I'd like to finish there and thank you very much, and apologies for all the walking healthcare workers and patients on my slides.
Panel session. This is going to be a first for us in terms of doing this sort of online virtually. We've got some questions that have already been submitted, and we've got our panel, including our patient speakers. So I've got some questions here that have already been submitted. I can also see the questions in the chat, so please do keep them coming. And I'm going to start with an ask for Dipti Radia. Dipti, are you on? Just some general vaccine advice. Hi, Dipti.
Hi. It's great. We've got light at the end of this long tunnel, which seems to have had an extension put on it with lockdown 3. But there is definitely light at the end of the tunnel with these vaccines. And we're doing pretty well in the UK. Kind of hard to remember that when we're sitting here in the dark on a January day. But on the whole, the advice, as we all know, is that vaccines are recommended, and we would recommend them regardless of your underlying condition. The general rules about vaccine, I think people are being concerned after the first Pfizer vaccine had the 2 anaphylactic episodes actually reported, is that they were specific for those 2 patients. There have not been any other anaphylactic episodes reported with any of the vaccines, and we've now vaccinated over 6 million people in the UK. So that should put it into context if you're worried about having some sort of anaphylactic reaction. I think everyone who should have a vaccine. I think there are specific things, and we're just talking about MPN at the moment, but there are people who may have other conditions, other comorbidities that might, we haven't got a handle on. So if you've got asthma or mild allergies or food allergies, you can still have any of the vaccines that are out there, the 3 that we've got at the moment, the Pfizer, the AstraZeneca and the Moderna. I know some of our patients have urticarian itching. It's not an allergic reaction, it's due to histamine release with the PV, with the basophils. You can still go ahead and have the vaccine. For those that have a lot of that sort of reaction, we would recommend taking an antihistamine about 30 to 60 minutes before the vaccine, and you'll know if you get that itching that it will be helpful. Only people that need to have a specialist manage their vaccination are those that have severe reactions to multiple drugs and anaphylaxis, or those that are on medication under care of an immunologist for anaphylaxis, and I don't think that would be this group in particular. So overall, a lot of people have lots of kind of allergic type reactions, but they're not allergies as defined for the vaccine not to be given. If you have any concerns, then you need to contact your clinician. But at the moment, there's no reason why 90 to 95% of the patients in the MPN group can't have a vaccine. Everyone gets a mild reaction by the arm. A lot of folk will get a bit of soreness. And from, I think I'll have to ask the reported cases back, it's tolerated generally very well. So for our group, I think those that have extremely a lot of pruritus and a lot of itching who are on antihistamines, I'd recommend don't change any of your medication, just take the antihistamine about 30 to 60 minutes before you have your vaccine for that added extra protection. Okay, I think that's the kind of generic bit on the vaccines.
Yeah, that's great, thank you. Though I can think of additional questions with regard to anticoagulation. Natalia, you've been working in the vaccine hub. In fact, I think most of us have been in and out of the vaccine hub. That we've given over, I think, 60,000 vaccines now at Guy's and St Thomas's alone. But there'll be people, I think, in the audience who are on anticoagulant drugs or who may have had a positive COVID test. So, Natalia, did you want to just speak about the advice about anticoagulation, your drug in general, and when you can have a vaccine relative to when you've had COVID?
Yeah, so thank you, everyone. Sorry, I have to wear my mask because we're few in the office, so I hope you can hear us well. So regarding the anticoagulation, it's okay to have the vaccine. If you're with warfarin and your INR is well controlled, then it's okay. If it's over 4 then we will probably delay that to avoid the risk of bleeding. Those patients with aspirin or clopidogrel or any of the DOAC like apixaban, dabigatran is fine. We recommend to press the area a little longer and observe that. But so far, we have not seen any problems with those patients. Regarding the other question, if you have COVID test positive, we recommend about 28 days between the infection and you receive the vaccine to just give enough time for you to recover, and then your immune system will be able to respond to the vaccine. But yeah, I think that's probably the most things that we have been looking on. Just to say that obviously when we're doing that I think Dr. Radia has mentioned before about the allergies, but we're doing an individual assessment for every patient coming to receive the vaccine. So these questions by the nurse, and then the doctors also review. And there's always a team on call for allergy and pharmacy. So if there's any questions that patients have regarding our medication or anything, we can, double check that in an individual base and then decide.
Okay, that's great. Thank you. And I can see messages in the chat from Mel and also Lauren talking about having had the vaccinations, maybe slightly sore arm and a bit tired the next day. I certainly took a paracetamol after my vaccine, but I would do the same after the flu vaccine. Dr. Ali, I wonder if you might comment. There's a few questions about which vaccine. So the only two vaccines that we're giving at the present time in the UK are the AstraZeneca or Oxford vaccine and the Pfizer vaccine. I know Dr. Ali, who many of you maybe have spoken to on the phone, Dr. Ali spent a year working on licensing agents, and so she knows an awful lot about it. So maybe you could comment on one, how these vaccines got approved so swiftly and the processes around approval. So you've been working for the European Medicines Agency. And secondly, do you think there's a difference between these vaccines, and should patients really focus on having one or the other? So Sarah, I hope that's okay for you to answer.
Yeah, of course. Hi, good evening. It's lovely to see so many people joining this meeting. I mean, this is a question quite a few patients actually asked me, which one is better and which one does have less side effects? I mean, they are both vaccines. They are manufactured in different way. And because they are manufactured in different way, the approval actually came swifter and quicker. So if you talk about the Pfizer vaccine, it's manufactured in the lab. So there is no virus, antigen or a surface part of the virus that one can make a model of it outside the body, which we call in vitro, and then produce antibody to it. So the Pfizer one is actually manufactured in the lab, and the way it introduces itself into the cell, it presents itself into the cell like exactly similar to the antigen of the virus, and to produce antibodies. So because the way of manufacturing it's so clever, actually the approval came quicker. Plus the fact that they had already recruited high number of patients or control group in this in the Pfizer study. The effect of it is highly effective. Some patients will asking, would it go to the nucleus? Would it change my DNA? Actually not. It's only a clever way, like, similar to the measles vaccine, but it is manufactured in the lab. So, and the measles, vaccine, we had the antigen which goes inside the cell. Then immediately when it produces the antibody, it dies. And this is exactly the same with the Pfizer vaccine. It's a manufactured protein which goes into the cell, trigger the immune system and die. It doesn't change your genetics. The response to it is actually quite high, and it claimed to be 90 to 95, and that's after 2 doses. The first dose will give you immunity, maybe much less than 90%, and you would need the second dose, but it is, immunity that can be effective in reducing the risk one would, expect. So that's touching on the Pfizer one. And going back to the AstraZeneca, AstraZeneca is, like the old method of taking, the antigen and then producing the antibody to it. The AstraZeneca is done here in Oxford, and it is effective. It is actually, studied on good number of patients in the UK, and some of my colleagues had guys participated in the study, which was, really quite good. So this one is, it does produce immune system, probably less than the Pfizer one. But the beauty about the AstraZeneca is that you can store it in, in an atmosphere which can be delivered to wider community. While the Pfizer one, because it's a new way of production, then you need to store it in freezing or very low temperature. And that restricts its, access to the community. Both viruses, both vaccines can be given to immune compromised patients. And that's another question. Can I have the virus? I've been told not to have, can I have the vaccine? I've been told not to have vaccines. These ones do not contain any virus. It's unlike the virally attenuated or the weak virus vaccine. They do not contain the virus. So yes, it is safe for immune compromised patients to have it. One cannot predict the response, but a response is better than none. Now, going back to Claire's question about approval and my experience in the EMA, I tell you, I mean, the FDA and the EMA, if they will, authorize any drug, they would have studied every little aspect of the drug. They would have studied what we called in the EMA the risk-benefit assessment, or the benefit-risk ratio. There would be a risk to everything. All the drugs that has been approved, there is, a risk, but the benefit should be, more than the risk, and the risk should be minimum. And I guess that both of these vaccines actually approved on conditional basis because the approval was so quick, and the follow-up and collected data would inform us more. So definitely the effectiveness, override the some risk or minimal risk has been identified, and hence it has been approved. And I would trust anything would pass by FDA or EMA after, working there and the meticulous, way of looking into data and analyzing the data. So I would be satisfied with the, approval. Thank you.
That's great. Sorry for asking you a complicated question. That was a great answer, though.
I hope I said it in a way that patients can understand. Thank you.
And we've got lots of questions on coronavirus here, and I don't know about you, but I'm really sick of coronavirus. I'm so over it. So I'm going to ask a couple more questions about COVID, and then I'm going to call COVID quits. I think we've all had enough about it. So one question I'm going to ask Jennifer O'Sullivan, and Jen, I think you're on the call.
Yes, I'm here. Hi.
Hi.
Hello.
Oh, you're sitting next to Natalia. You're both wearing masks.
Far end of the rooms.
So, Jen, do you just want to talk about our experience about, what about MPN patients? Are they at higher risk of catching COVID, being affected more seriously, getting blood clots? Obviously an evolving field, but would you mind just talking briefly to that, please?
Yeah, so I mean, I guess that's a big concern for everyone, I guess, who is on the call. But in the UK, are experiencing and looking at an observational group of patients who've had COVID with MPN. It looks largely that compared to, say, the normal population. So the risk of contracting it is probably similar, and the risk of how one gets it. But then in terms of having more severe COVID and needing to be admitted to hospital and maybe intensive care, really the risk is associated with older age. And, you know, some of the patients who have more severe COVID with MPNs have been on treatments and even ruxolitinib. But the largest predictor of having severe COVID was, as with the general population, as one gets older. And it looks like people with who are younger with ET or PV, the risk was reasonably similar to that of people without MPNs of a similar age. Although, you know, from the data we have and looking across different cohorts internationally, the numbers are small. So I would say what we think really is that there is a marginally increased risk, but it wouldn't be the big driver of risk factor for patients. So what we see is more when as someone's getting older and maybe other conditions, so heart problems or diabetes or high blood pressure. But it's something we will be mindful of, and that's why we do have that additional layer of recommendation for people to protect themselves more so than the normal population.
Okay, thanks very much, Jen. Claire Woodley, I'm going to come to you now and just ask you, when you get contacted by a patient and they say, I've got a positive COVID test, what advice do you give that patient? So I know you've done this a lot. Could you tell us what advice you'd give a patient? At the moment, we can't hear you.
Hi.
Perfect.
So I think for us, patients tend to contact us via our helpline that we have. Generally, when patients call in, we are assessing what the symptoms they currently have. We're asking patients to monitor symptoms, so to keep track of temperatures, to monitor their breathing. Some patients will already have oxygen probes at home where they can monitor their oxygen saturations. We're encouraging patients to keep well hydrated. And generally, that if symptoms are not improving or are not getting any better, or if they're getting worse, then to contact us early so that we can then advise whether they need to seek medical review. We do have a lower threshold for encouraging patients to seek review if their symptoms are getting worse or if they're struggling with their breathing at all.
Great. And just lastly, Donal, about ruxolitinib and COVID. So we're particularly interested, of course, in, you gave that beautiful talk, even though the women kept walking off. That's what happens if you're the man in a female team, I guess. Just, sorry to be flippant, what do we think about ruxolitinib specifically and the vaccine? And then I'm going to finish COVID by coming to Nona and asking her about how we can maybe look after ourselves at the moment. But just some comments about ruxolitinib and myelofibrosis patients in particular. Any particular messages?
Yeah, so I suppose there's three main things to think about. So I think the first thing is for any patient who has myelofibrosis on ruxolitinib, it's really important that if the patient is unlucky enough to contract COVID, however severe or mild the COVID may be, that there's no sudden cessation of the drug, because across Europe, one of the factors that was determined with a more difficult outcome was that if a myelofibrosis patient had moderate or severe COVID-19 and the physicians, for whatever reason, stopped the drug, that they had a more adverse outcome. So that's the first message about patients who are on ruxolitinib. The second message is, we don't fully understand how ruxolitinib may or may not affect the response to these vaccines. We've done some work within the team at Guy's looking at responses to influenza vaccines, similar to the work that I've just shown you from Patrick. And when we do see that we do form memory cell, both B and T cells to the influenza vaccine, so there is a good immune response, but maybe not as robust as that in someone who does not have an MPN and is not on a JAK inhibitor. But the jury's completely out on that for ruxolitinib and COVID-19, and that's why we're doing the current study. And the third message would be with ruxolitinib. As you know, many of us on the call may have heard about ruxolitinib being used to treat patients with COVID. There was a multinational global trial that has stopped. They were using a very small dose of ruxolitinib, 5 milligrams twice a day, and it didn't show benefit at that dosage in patients who had, or in individuals, so these are not patients, individuals who may or may not have an MPN who contracted COVID. So that small dose did not seem to give a beneficial effect in dampening the inflammation with very severe COVID. So those have been my three main messages, but really we're looking forward to having data about the immune responses for all of our patients to the vaccine. And I think that's a really important next step in understanding how we move forward with this.
Okay, that's fantastic. Thank you. And before I come to you, Nona, I'm just going to answer myself. Can't keep chucking patients questions at other people, otherwise they'll get their own back on me tomorrow. Some questions about shielding, and Dipti's pointed out the question from Rachel about in the chat about group 4. So way back during the pandemic, there have been all these questions and lack of clarity about shielding and patients with MPNs. Because we know that many patients with MPN are fit and well, go about their everyday life, are fine, and want to forget about having the disease. So to be told you've got a blood cancer is bad enough, but then to be told you have to shield is also difficult. But the problem with the shielding thing, which we've rehearsed a few times through forums, is, you know, the difficulty in differentiating out risk individually across treatment, different diseases, etc. So as a group of doctors in the UK, we decided that MPN patients should ideally be shielded and therefore should be under group 4. I can see a lot of toing and froing in the chat and in this big group list of questions I've got here about whether patients should be in group 4 or group 6. In general, at Guy's and St Thomas's, we think we've put all our patients into group 4 on a shielding list. You will get a text message if you're one of our patients inviting you to come to us for a vaccine, but you don't have to go to Guy's. You can go anywhere for a vaccine, or you make your own decision about whether you want it or not. I think it's difficult and it's a struggle, the whole kind of cancer definition thing. It's a big issue, but in general, our view is there is an increased risk, and we would offer the vaccine to our patients. I appreciate that that varies a bit, and we always struggle with issues about knowledge in family practice, etc. And I have a lot of sympathy with GPs with regard to that. So Nona, the last time we did one of these sessions, we had Abby, who's one of our psychologists, give a fantastic talk about looking after yourself during this time, and giving tips, and this has been downloaded lots of times from the website, and also Paul's videos that he's put on the website about looking after yourself. Is there anything you would like to say with your professional hat on with regard to looking after oneself during this time?
Thank you, Claire. I agree with you that the resources we've got on the website, Mary Moriarty also did a wonderful talk on well-being for the Irish Patient Forum. And I think they're well worth revisiting for anybody who's struggling with anxiety. I think words are important, actually, and shielding was a really difficult word for people to come to grips with. I think being kind of locked up for so many months has been challenging for people. I think also for looking after ourselves, it's important we take time just to chill out. Watching too many news bulletins or daily doses from Downing Street can somehow create a little bit more anxiety. And I know, listening to people, the other thing is that the face-to-face appointments with their clinicians around the country haven't been as forthcoming as they could have been. So people are having to adapt to having to have telephone consultations for the time being. And I think what the important thing is to think about sometimes what is right now, because we can allow too many what if this, what if that, what if the other, always giving ourselves negative answers. And so sometimes just to sit and think, what is right now? And actually, essentially, right now, in this moment, we are all okay. So I think my tip is to try and avoid too much giving yourself the narrative of what if this happens, this will be awful, this will be that, this will be that. And actually just try and give yourself a little bit of kindness and thinking, I'm okay. Right now, I'm okay. Because there is a lot of bad news around. As Deepti said, it's getting better. But I think it's been a long year. I mean, and I fully appreciate for the clinicians here, it's been extremely tough. And I want to acknowledge that because you guys have been on the front line. You will have lost patients who are colleagues, patients, MPN patients who you've known for a long time. And I think that in itself is stressful. And so I just think tuning into one of Paul's podcasts, tuning into, there are plenty of mindfulness apps or stress releasing apps, things that can make you feel calmer and make you feel more centered and living in the present are all good things. And I wish everybody well, because it's been incredibly tough, and particularly to the medical staff here, who I appreciate will have had an unbelievably tough time. Those are just my thoughts.
Thanks very much, Nona. That's fantastic. So, Sarah Najabat, are you still here? I want to ask you a question.
I am.
Hello. I want to thank you so much for your story. I wonder, though, as a pharmacist, whether you might feel able to just give some tips to people about what they could ask for from their pharmacist with regard to MPN or, for example, not talking about COVID, but talking about things like being fit, cholesterol tests, etc., drug interactions. Do you feel able to comment on that?
Yeah, sure. I don't know if many people know this, but in pharmacies, pharmacists normally do medication reviews. If you start on some new medication, we do have a review where you speak to your pharmacist about what to expect from this medication, and if you get side effects, to contact the pharmacy and speak to the pharmacist about, you know, what to do about those side effects. So there is loads of advice available at your local pharmacy, whether it's a minor ailment, like, you know, if you're just feeling unwell and want some advice, you can just contact the pharmacy for, you know, what you need to do. There is, in most pharmacies, community pharmacies, there are blood pressure tests available, there is diabetes checks available, cholesterol checks available. And, you know, if you want to have a quick check and you can't get to your GP, I know loads of pharmacies, not just Tesco Pharmacy, but even independents provide these sort of services, most often on a walk-in basis. So if you need advice on just general lifestyle tips, you know, even weight management, loads of pharmacies do provide that, you know, in terms of programs, nutritional programs to help with weight management. There is loads of things at your local pharmacy, so you don't necessarily need to go and see a GP. Because pharmacists are well trained to talk about any medication that you're taking, what to expect from it, what to do if that medication doesn't suit you, and who to refer you to. And I think, you know, there'd be great help and advice if you need something without an appointment, or if you just want to pick up the phone to your pharmacist and say, I'm not feeling great today, you know, what do I do? What shall I take? they'll be great help and support. And they are just there really without an appointment, so you can just get to them much quicker than you would to a doctor or a GP. And most often they can help resolve issues that is just, sort of based on advice or what you need over the counter, or like I said, just general health checks, which includes blood pressure, diabetes checks, cholesterol checks and things. And all pharmacies have got consultation rooms, so you can do this privately in the consultation room and be given the advice that you need.
Okay, that's fantastic. So no excuse. You all need to have perfect blood pressure and perfect cholesterol. There's no excuse because of the pandemic for letting that go. These things are all really, really important. Caroline, I'm going to come to you next, just to say, what would you say to anybody who wants to volunteer to be part of sort of advocacy or being a buddy, etc.? Anything to mention? Is it onerous, stressful?
Yeah, I mean, it's not stressful. It's fun. Sorry, my my little one is eating her dinner, and she's wondering why she's got a herb on her finger, so she might be a bit noisy for this. So it's not onerous, it's not stressful. It is what you want it to be. That's what I found with the advocacy work. So when I started the advocacy work, I was studying for a degree and working full time as well, and it was quite a lot. It was quite a heavy workload, studying in the evening and working in the daytime. But I managed to make the MPN work fit in around it. I think it helps if you choose an area where your skills are aligned. I think that helps, because then you're using skills that you've already developed. It takes pressure off. I then stepped back from advocacy work when I'm so sorry about the noise in the background.
Great multitasking, and it's lovely noise. You like it.
Bless her. So when I became pregnant with Charlotte, I'm gonna move away from her. When I became pregnant with Charlotte, I stepped back from advocacy work because I was too tired. I had too much on. I was working. I was still doing my degree, and the advocacy work was too much. But I was able to step back, and then now that my degree is finished and I'm not working anymore, I have more time. So I've been able to step back into it. So it's not the kind of thing where if you sign up, that's it. You're signed up for life. It's when it works for you, you can do what you can do, and when it doesn't work for you, you can step back, and there's no judgment on that. I really do recommend it. For me personally, from a psychological perspective, it's making a positive experience out of something that I would rather not be happening in my life. But with the advocacy, it's positive. So no, definitely not onerous or stressful. It's actually quite fun.
Seasoned multitasker, I can tell. Thank you so much. Sorry to interrupt.
You're welcome.
Your house. Right. Lots of questions about progression. So I'm going to introduce you to another member of the team, Priya. I think, Priya, you're online.
Hello.
Hello. Thanks for joining us.
Thank you.
We can tell you're sitting near Jen.
Socially distanced.
Lots of questions about how will I know if my disease is progressing? Did you want to just kind of talk to us a little bit about that? Would be fantastic.
Yes, I'll try and give it as a brief summary. So obviously all of you know your disease very well, but I think the main thing is a lot of patients do notice that they may feel more tired than usual. Some of you, if you do have sweats and it seems to go down with treatment, start intensifying again, may get more itching as well. Another thing to be aware of is sometimes your spleen can get a little bit bigger, so you may notice that you're not able to manage meals as much. Your appetite's going down as well. Other things could be, for example, you may notice new bruising or any funny bleeding symptoms. you may also be more prone to infections as well. So I think if you do notice any of these, it is a time to go and speak to your local team and get advice from them. That's it.
Thank you. So Claire Woodley, quick chat about how to monitor these things then, and monitoring of symptoms would be good from you. Some words of wisdom. And then I'm going to ask Donal about treatments for progression, because there's some questions in the chat about endpoints in trials. Thanks, Claire.
Yeah, I think we all have our own views or our own ideas when we talk about the different symptoms that patients are experiencing. So what might be fatigue to one person is a different when you ask a different person levels of fatigue. So I think symptoms are very much an individualized experience. What we do use is a symptom assessment tool. And this is a very good tool called the MPN 10. It covers 10 symptoms that we know are particularly relevant for patients who experience these conditions, and ranges from things such as fatigue, itching, do you fill up quickly when you eat, how is your itching, do you get bone pains, are there temperatures? Now these 10 scores range from 0 to 10. 0 being that you don't experience them, and 10 being the worst that you can imagine. Now, there is no right or wrong score for these symptoms, and it's very much what you feel your symptom is at the time. And a one-off score might tell us how a symptom is at that particular moment in time. But I think for us as clinicians, it's better that we get a range over time, so that the patients can get this scoring system online, and you can do it at home perhaps once a week, and then you can take it to your consults with you. It's very good when you're on a telephone with a consultation, because it you know, we don't have that same looking as a person as they walk into our clinic room. So and then you get a score over time, and generally we look at scores that are perhaps, if a score is over 20 or is one particular score is above 5, then that can give us an indication that actually this is quite problematic for the patient. It can encourage you in a consult when perhaps you don't feel you're able to talk about your symptoms, to focus a consult and to say to a clinician that this is what is problematic for me. And over time, we can see how those symptoms change. So, you know, you may have a score of 20 one week and it may be 30 the next week. Now, that suggests to us as clinicians that something has changed for you, and that symptoms have changed, and perhaps something is more problematic, or there may be something that we need to address for you in particular. So, you know, I find them particularly helpful in consults in working out what is important for that patient at that particular time. It's very easy to walk into a consultation and be told your bloods are fine, off you go, everything's good, and you leave a consult thinking, so why am I then so tired that I can't get out of bed every day? So I think it's good to monitor symptoms. It's good to use something that's objective, such as a symptom assessment tool. And over time, as I say, we can track these numbers and we can see, well, you know, what makes it better for you, what might make it worse for you at a given point in time.
Absolutely fantastic. Thank you very much. So now I'm going to come to Donal and ask him to, there's a question in the chat about progression, but I wanted you, Donal, if you wouldn't mind, just to broaden the question out a bit to what do we know a bit about science around disease progression and therapies, etc. So a broad question for you, because I know that's really a big area of interest for you, and you've made big contributions in that.
Yes, I think it's a really important concept that none of the trials initially that were designed to look at this very important topic of progression, particularly either with PV or ET to myelofibrosis or more advanced disease, or myelofibrosis to blast phase disease. And there's a big focus within the global MPN medical, scientific and patient community to focus on what we mean by progression and how can we predict progression. So I think globally, most of the large MPN centers are focusing, at least in part, on the progression modeling. And that encompasses really some of the things that we focus on in guys. So looking at the immune system background in MPN and how that might change over time, and how does that contribute to the acquisition of types of mutations or numbers of mutations? And is there any signature that we can look at before progression happens? So you'll all know, particularly for patients with myelofibrosis, we look at blood smears, we look at blood counts, we look at symptom scores, we measure spleens, but is there anything more defined that we can do to look at immune changes that happen before we actually see the increase in blasts or the increase in fibrosis? So there is a big global push to look at this overall. I think a lot of that will be trying to delineate some of the work that Claire has shown about the molecular landscape, but I think it isn't just going to be one particular point. It's tying that up with clinical features, blood count changes, and the immune system changes in particular. So I think we'll probably at ASH in the next few years, looking at how projects are being funded on a global basis, see a lot more data focusing on particular progression. I think somebody has asked a question about the combination of, so Colin, thank you for the question, has asked about ruxolitinib and Novita Clax compared to Pegasus on changing JAK2 mutation burdens in the absence of these high molecular risk mutations. So a very important question. The honest answer is we probably don't know as yet, because there's only less than 40 patients at the time of the presentation of ruxolitinib and Novita Clax, and there were 19 who had high molecular risk mutations. So I think more data is needed on the combination studies and changes. It is very encouraging, even with that small number of patients, there were 33 patients, we did see a proportion who had downregulation in the amount of these high molecular risk mutations alongside. How that compares to Pegasus, again, is an unknown, because we have long-term data on Pegasus and effects on JAK2 burden, but we only have 6-month data on the combination study. But a really important question, and something I think all this progression work should look at, now that we have all these multiple combinations coming into the clinical trial field.
Okay, that's great. So I can see some questions about pregnancy and about familial disease. I can see, I think it's, sorry, I've got my glasses on, but I'm struggling. I think it's Susan has just put a comment in the chat about she's diagnosed age 49 but had some very difficult pregnancies. It must have been very trying for you at that time. Someone's helpfully made it bigger for me. Thank you for that. I'm wearing my glasses, but struggling. So Susan, I'm so sorry to hear about that, but also happy that your baby was okay. It is possible that this problem with your pregnancy could have been related to the MPN. And I'm thinking that you're probably thinking that because of the Jyoti's data that we showed earlier. And when we find patients at the time of diagnosis, often we do find that patients may have had, particularly women, may have had problems with miscarriages in pregnancy, or some patients have had blood clots earlier on in the year or two before diagnosis. And that's one of the things that's really important from Jyoti's work about understanding earlier diagnosis and the implications of. I've also seen a question in the chat about, or it may have been one that was submitted. Actually, Debbie Street, you submitted a question before the session about my grandmother had PV and I am ET JAK2 positive. Is this a coincidence? I think there's a long answer to that, which would probably send lots of people to sleep. But there's a short answer, which is there definitely does seem to be some tendency for some sequences in the DNA to be inherited, which it makes it more likely that a patient will develop a JAK2 mutation. But familial ET or PV is actually quite rare. When our patients like Caroline have babies, we don't test their babies for this disease. That's clear because actually we might not be able to pick up a mutation. And we generally do not recommend that family members are tested, but there is a very small risk. Across the UK, we've been trying to collect together families who've got a story like yours, Debbie, and just try to understand a bit more about the nature of disease and how it might happen, because that will actually help us to reverse that, reverse engineer it, and try to stop it. So do let your doctor know if you do have a family member with a condition like MPN. So there's a common question that maybe I'll come to you about, Dipti or Donal, if you want to answer it, about vaccination, but not COVID, vaccination and return to work, vaccination and still shielding. Whichever of you wants to answer that. I don't know, Dipti, do you want to? Because Donal's spoken recently.
Donal can take the baton on about it afterwards. I guess one of the things here is that at the moment, if you are in the clinically vulnerable group, then the consensus is you still need to continue shielding, even if you've had the vaccination, especially if you've just had first dose, and then wait for the second dose to get the full protection. That's more about staying safe from the other variants and making sure that you are protected. So I think in terms of shielding, you have to follow the government guidance. You do need to stay in and be safe with the hand washing and the hygiene. And returning back to work, I think there's a lot of, I think what we have with the MPN cohort, as with a lot of diseases that have a spectrum, are all within a single clinically vulnerable group. But then we're talking about what is that risk? How high is that risk, or how low could that risk be? And I think if you are at work, you need to liaise with your occupational health department to work out, because everyone's got different jobs, to work out what the risks are. You know, the message is going to be, if you're able to work remotely, then you should do so for your own safety as well. But there are obviously jobs that you can't work remotely, and people have to earn a living, and also for mental health. So I think it's liaising with your occupational health department and working out those individual risk assessments. Donal, I'll hand over to you for any additional bits.
No, I completely agree. And I think irrespective of whatever vaccine we're all lucky enough to receive, then I think it completely applies until we get more data.
Yeah. I mean, you'll see that most of the healthcare team have been vaccinated, but we're still wearing a mask. We're still being really cautious. A vaccine doesn't stop you from having the virus. It stops the infection from being bad. Your immune system picks it up and wipes it out more quickly. So it's still possible to pick it up, and it's still possible to pass it on. Over to you now, Nona.
Well, first of all, to the community, I'd like to say a huge thank you for your ongoing support. I'd also like to take a minute to reflect on where we are. I mentioned earlier that the teams in the hospitals are facing unprecedented pressures. And I also think we should spare just a minute's thought for Captain Tom, for what he did for the NHS, and for his courage, and for what a huge loss his death will be to his family. But not just him. Claire told me that there are nearly 1,500 other deaths today, for everybody, and everybody connected with the caring professions. Or I think this pandemic has affected each and every one of us in some way or other, whether it's anxiety through shielding or knowing somebody who's ill. And I just would like us to, just before I go on, just take a minute to think about all those people and all the wonderful people that are doing so much for us. So if we just take a minute in reflection of what these people are doing, and particularly for Captain Tom and his family. Thank you, everyone. I'd like to also take this opportunity to give a special mention to everybody at Guy's and everybody behind the scenes who's done so much, the people who've given up their free time, the medical staff, who's done so much to make this evening possible. Not forgetting Maz, our administrator in the background, who we couldn't really do a lot without Maz. And I just would say, I know Maz, the community really appreciate everything that you do. And also to the team at Guy's, the Event Commercial Service Directorate from Guy's and St Thomas's National Health Foundation Trust. And that is Danny, who we've been emailing quite regularly, Drew, Dean and Tam. You've all done an amazing job. And I think that I'd like to just do a clap for all of you, because without your help, we could not have put this on. And, you know, everybody who's been helping us, I have to say, every single bit of your help is so appreciated by all of us. You know, it's a very difficult situation. It's an ongoing situation. We are planning to do more virtual forums, and keep an eye on the website for that. And, you know, I really do ask you, as Claire said earlier, please could we have your feedback forms, because that helps us formulate plans to meet the patient needs. And so we will really appreciate getting those back as soon as we can. We hope that sometime later in the year, we have to be optimistic, we might be able to have a face-to-face meeting. We can't guarantee it. It is our aim to get back to having face-to-face meetings. In the meantime, we really all look forward to seeing you again. Thank you, Claire. Thank you all the team at Guy's and St Thomas's. I think I can sit here and say this has been a successful, very successful first shot at doing breakout rooms. And just a final thank you to Novartis for helping us put this on. So from me, it's farewell, and we really look forward to seeing you again very soon. A big thank you to the NHS, and stay well and keep safe. Thank you, everybody.
Can I just jump in and say, I would like to say a massive thank you to all of the team and everybody joining, but actually a massive, massive thank you to you, Nona, for everything that you do for MPN Voice in the patient community and for this wonderful forum. Again, you've done another excellent job in chairing this forum, and it's been absolutely brilliant. You've done a fantastic job once again, and we've nailed another forum. And I know you were worried about it and getting nervous. You've done an excellent job. Well done, you.
Thank you.
Thanks, everybody. Take care. Stay safe.
Thank
Bye.
you. Bye, everybody.
Bye-bye.
Bye. Bye.
Thanks, everybody. Excellent.
Bye.
Thank you.
Thank you. Thank you.
Bye-bye.